Good evening, everyone. Welcome to the webinar on Hodgkin's Lymphoma Expert Connects Advancing Care in 2026. It gives me great pleasure to invite our program director, Dr. Pavan Kumar. Over to you, sir.
Oh, uh, yeah. So I think we have a first session by Dr. Madhav. So starting to keep the session going. So I think everybody understands that Hodgkins has totally changed. The management of Hodgkin has totally changed over the last 2-3 years. Now with the options of available of brentuximab, which was available for 3-4 years, and now Nivo is coming into picture. The whole treatment, it's still confusing actually to many of us. And I think from here, there are a lot of discussions and probably our own customized treatment will come into picture because we have data for both things, brentuximab, nivolumab and all. I think let's see what is the evidence right now and what is the easiest path to go ahead. I think Dr. Madhav can start the session of raising bar in Hodgkin's lymphoma management in present era. Thank you.
Okay, very good evening. I hope you're able to see my slides. One second.
Not yet, sir.
Can you see my slides now?
No, sir.
Just one sec.
Yes, sir. It is visible now.
Very good evening. I'm a little under the weather, so if I cough in between, please excuse me. So the topic given to me is raising the bar in Hodgkin lymphoma management, focusing on evidence-driven strategies for better outcomes. First slide is looking at how Hodgkin lymphoma still continues to be diagnosed in advanced stages in anywhere between 40 to 80% of patients, depending on where they're from. And also the fact that despite Hodgkin lymphoma having curative options, there's still a subset of them, roughly 5 to 10% of patients who do have primary refractory disease, and around 10 to 30% of them do experience a relapse after initial response. And among patients with advanced Hodgkin lymphoma treated with first-line ABVD, up to 30% of them progress or die within 5 to 7 years. This represented an unmet need for treatments in advanced Hodgkin lymphoma. And this is the space that the newer regimens tried to improve on. Again, Indian landscape, the median age at diagnosis is around 38 years. And despite frontline care, as I'd mentioned in the previous slide, a quarter of them do progress or die within 5 years. So, what is the state of art for advanced stage Hodgkin lymphoma? Well, the first regimen that changed the standard ABVD was based on the results of the Echelon 1 trial, which was 6 cycles of BV-ABD, and the 7-year data was reported to be much better than ABVD. The other direction that we've headed in Hodgkin lymphoma, now because it had such good cure rates, the focus was on minimizing toxicity, which led us to a PET-guided approach where de-escalation was sought if there was a good response in the interim PET, or an escalated strategy if it was the opposite case. Also, depending on where the patient is treated, for instance, the German Hodgkin study group, the HT18 trial, the standard of care is 6 cycles of escalated BACOP. They favor the escalated BACOP more than the other regimens. And in order to improve on the toxicity while still maintaining efficacy, they are pushed for the HT21 trial, which was individualized PET2 guided BRIOCAD versus escalated BACOP. So we will be focusing on brentuximab data as part of the BRIOCAD approach. And we will also touch upon its comparisons with the SWOG trial, which looked at Nivo AVD versus BV AVD. So I would look at this talk as, trying to find a place for BRIOCAD in the current scheme of things. So one of the first arguments in favor of the Briacad approach is the duration of treatment. Right. So the first question is, can Hodgkin lymphoma be treatment be completed in a much shorter time frame? And this is a self-explanatory. A shorter time obviously means that there is a return to work much sooner and there's recovery of fatigue at an earlier timeline. So this is what this was the Briacad approach. So Brentuximab instead of bleomycin, and this was to reduce the risk of bleomycin-induced pneumonitis, which is a very worrisome adverse effect, especially in the young. Etoposide, the dose was reduced from 200 to 150 milligram per meter square, and this was to reduce the incidence of secondary malignancies. Doxorubicin, the dose was increased from 35 to 40 milligrams per meter square, and this was to try and maintain a cumulative effective chemotherapy dose because they had reduced the dose of etoposide. Cyclophosphamide dose remained the same in both Biacop and Briacad. Vincristine was omitted, and this was a decision taken because of the results of the BVAVD, where there were overlapping toxicities that led to a much earlier discontinuation rates. Procarbazine, part of the Biacop, was replaced with dacarbazine, and this had a major impact on reducing gonadal toxicity and also reducing the risk of second malignancies. The steroid of choice in Briacad was dexamethasone, and it was given only for 4 days compared to the extended 14-day prednisone in escalated Biacop, and this was with an intent to reduce the risk of infections during the aplasia phase. So there were quite a few changes made to try and improve the toxicity profile of the regimen. And if you look at the exposure to anthracyclines in Briacad for patients who receive, because it was a PET-guided approach, those who are PET negative end up with receiving 4 cycles of Briacad, and the cumulative anthracycline exposure is 160 milligram per meter square, compared with 240 for the Briacad 6 cycles, as against 300 in the ABVD regimen. So recent research has shown that cumulative doxo exposure above 200 milligram per meter square is associated with a 1.5 fold increased risk of developing breast cancer in Hodgkin lymphoma survivors. So lower anthracycline exposure was seen as an attempt to reducing both the risk of developing cardiomyopathy and congestive heart failure, and also the risk of malignancies in the follow-up period. So the HD21 was a large phase 3 randomized multicenter trial across 9 countries, and roughly around 1,400 patients were recruited. The rationale, like I had mentioned, was making modifications to the escalated Biacop regimen to reduce toxicity while maintaining the high efficacy of escalated Biacop, and still attempting cure. Again, inclusion criteria, age 18 to 60 years, because both escalated Biacop and Briacad are seen as intensive regimens. And so the cutoff for inclusion was 60 years. That's an important factor. Also, advanced classic Hodgkin's lymphoma, stage 2B with large mediastinal mass and or extranodal disease lesions, and stage 3 and stage 4 were included. NLPHL patients were excluded. And this was in newly diagnosed Hodgkin lymphoma patients with normal organ function, good ECOG PS, and HIV negative. So patients were randomized to receive either escalated Biacop or Briacad. There were 740 and 742 patients on each arm, respectively. An interim PET was done after 2 cycles of assigned therapy. Patients who were PET negative went on to receive 2 additional cycles of Briacad for a total of 4 cycles. And those who were PET positive at the interim PET2 received 4 additional cycles of Briacad to complete a total of 6, at the end of which a PET restaging was done. Those who were PET negative were followed up. Those who were PET positive received consolidation radiation therapy. This again, HD21 did employ a PET-adapted study design that allowed for de-intensification of chemotherapy in patients with early response, and I've also mentioned the study design in the previous slide. The co-primary endpoints of the HD21 trial were progression-free survival, a non-inferiority endpoint, and also a treatment-related morbidity, which was a superiority endpoint. So these were the two co-primary endpoints. Secondary endpoints were overall survival, therapy adherence, quality of life, infertility rates at 1 year, second malignancies, and serious adverse events. So looking at the results of the HD21, first looking at treatment-related morbidity. Now, Briocat was associated with lower rates of grade 3 hematological adverse events, and at 1 year post-treatment, hematologic treatment-related morbidity had resolved fully or to grade 1 for all patients in the Briocat group. The incidence of febrile neutropenia was much lesser in Briocat, as was the incidence of grade 4 cytopenias. Looking at the other co-primary endpoint of progression-free survival, the estimated 3-year PFS rates with Briocat was 94.9% compared to 92.3% in the escalated Briocat arm. Now, we always knew that escalated Briocat was one of those regimens that we would prefer in young, fit patients, and we would always get good outcomes and long-term follow-up if they survived the regimen. What's interesting to note is that the 3-year PFS rates of Briocat was better than escalated Briocat and is in fact the highest PFS rates achieved across the board, which we will discuss in the later slides. So the 3-year analysis demonstrated non-inferiority of Briocat versus escalated Briocat with a hazard ratio of 0.63. This was the 4-year analysis, and the same progression-free survival rates continued in the 4th year and the 5th year analysis as well, that was presented in ASH 2025 after a median follow-up of 60 months. So Briocat did show a pronounced 5-year PFS benefit compared with escalated Briocat, and especially if you look at patients who are PET negative, the PFS was 96.2% for Briocat versus 92.4%. And among the IPS variables, male gender and hemoglobin less than 10.5 were associated with a higher risk of PFS events. But the 5-year overall survival was 98% for both groups. So PFS by PET status, again, 64% of patients in the HD21 were PET negative. So roughly 2/3 of patients were PET negative and ended up receiving only 4 cycles. So more than 50% of patients receiving an abbreviated course of treatment is definitely a significant thing and something that favors a choice of Briocat. Again, subgroup analysis, not much to read from it other than the fact that it did favor the hazard ratios favored Briocat in younger patients, females and patients receiving 4 cycles. Safety profile, one of the things that the trial looked at was the incidence of peripheral neuropathy. If you look at the BV-AVD data, the grade 3 and grade 4 peripheral neuropathy was very, very high because of the combination of 2 microtubule inhibitors. Compared to Briocat, the most frequent organ toxicities, grade 3 or grade 4 was 19% in Briocat compared to 17% in escalated Briocat. Severe sensory peripheral neuropathy was rare and persisted at 12 months in only 1 patient. So even though patients did end up getting grade 2 or grade 3 peripheral neuropathies, by 1 year, most of the neuropathy scores had improved significantly in the Briocat arm. Primary MDS or AML occurring as a second malignancy was a rare event, although the timelines need to be, this data needs to be analyzed further because of the timelines when patients do develop second malignancies. Again, infertility concerns with escalated Briocat are there, and the fertility-related data, FSH recovery at 4 years was significant with Briocat. Many more patients in the Briocat arm had a fruitful pregnancy compared to those on the Briocat arm, and that was something that was a positive in the Briocat arm as well. Improved tolerability and sustained dose intensity for optimal results as well. So a lot of patients had continued to receive treatment in the Bracad arm without dose reductions. And there was a difference of 20% between the two arms by cycle 4 and 25% by cycle 6. So early termination of tubulin inhibitors in the Bracad arm was 2.4% compared with 18% in the escalated Biacorp arm. And there was no difference in groups that were PET negative in both arms. They had also looked at the QL patient-reported outcomes, and Bracad did demonstrate that they had lesser peripheral neuropathy, cognitive fatigue, and dyspnea, and higher functioning and global health status in the first and second years post-treatment with Bracad. So, which brings us to its main comparator in our clinical practice, which is basically the result, what followed with the results of the SWOG study. Now, the SWOG study does not employ a PET adapted approach. It offers to give 6 cycles of Nivo AVD for patients who are in stage 3, stage 4 Hodgkins, and its comparator arm was Brentux with AVD for 6 cycles. And Nivo AVD versus BV AVD, the 1-year PFS in the intention to treat analysis was 94% versus 86%. So there was quite an early fall off in the BV-AVD arm, and that was mostly discontinuation rates in the elderly population. So again, this is a different strategy employing PD-1 inhibition compared to what is done with BV-AVD. And data, if you look at patients who are included in the arm, there were patients who were above the age of 60 as well, going up to 83 years. And that's one of the reasons why we saw a lot of toxicity upfront in the BV-AVD arm. And BV-AVD was also the arm that had to be on GCSF prophylaxis as well in the arm. So at the end of it, the 3-year estimate Nivo AVD 91% compared to 85% with BV-AVD, and BV-AVD kind of fell out of favor after these results. So what are the issues with the Nivo AVD that aren't discussed often? It's a different toxicity profile, and we are very aware that immune-related adverse events are quite frequent in the Nivo AVD arm, at least in real-world clinical practice. And the incidence that was reported in the trial with grade 1 and grade 2 immune-related adverse events was 23.2%. And the incidence of grade 3 and grade 4 was 9%. And this was actually much lesser than the immune-related adverse events that are reported in other immunotherapy trials. So that is something that needs to be considered. Hospitalization for adverse events in the Nivo AVD was roughly around 20%. And that was mostly to do with having to admit for immune-related adverse events like pneumonitis and patients requiring steroids as inpatients as well. So this is a slide depicting all the possible immune-related adverse events because of the Nivo AVD. And in the S1826 trial, there was 9% of patients who had discontinued Nivo. And this there was definitely a discrepancy to other anti-PD-1 first-line trials with limited follow-up. And this is something that has to be looked at. So which approach is the right approach, or when would you choose Bracad over Nivo AVD? Are there other things that can guide us? So one of the strong arguments in favor of Bracad is that the overall treatment duration is only 12 weeks for 2/3 of patients. So patients who are PET negative end up getting just 12 weeks of treatment with 4 cycles of Bracad. And that is quite significant compared to the time spent receiving 6 cycles of Nivo AVD, which is roughly around 6 months. So that is one criteria that has to be considered. Second is, again, if you look at the outcomes in patients who are PET positive, I think this is one of the biggest differences in both in the data. If you look at the 5-year PFS for patients who completed 6 cycles of Bracad, it's still 90%. You compare this with the 3-year PFS rates with Nivo AVD for those who were PET positive, it is 68%. So PET negative, not much of a difference. In PET positive, there is a big difference in the PFS between Nivo AVD versus Bracad. So PET-guided Briocad or on other key aspects, like we had mentioned in the previous slides, 3-year PFS in high-risk patients, 91% versus 68. Similar outcomes in lower risk patients. Acute toxicities, you're looking at more infections, more transfusions, higher utilization of healthcare resources, more prolonged admissions, and burden on the hospital system, compared with more immune-related adverse events with similar hospitalization rates in the Nivo-AVD arm. Again, cumulative doxorubicin exposure, patients who are PET negative, 160 milligram per meter square in the Briocad compared to 240 in those that receive 6 cycles, compared to 300 in Nivo-AVD. Late toxicities, persisting or late toxicity relevant for less than 1%. In the Nivo-AVD arm, patients who do end up having immune-related adverse events might have long-term toxicities as well. Unplanned hospitalization rates are similar in both arms. So these are the criteria that differentiate Briocad versus Nivo-AVD in our clinical practice. Slides are not moving. Yeah. So there's this was a global meta-analysis that did a cross-trial comparison. There is obviously no head-to-head data between Nivo-AVD versus Briocad, and so we have to rely on such comparisons. This meta-analysis, for instance, did show that PET-adapted Briocad led to better PFS than other therapies, but was accompanied by higher rates of febrile neutropenia. And the PFS regimen with the regimen with the highest PFS is Briocad with 94.9% compared to the other data sets. But again, all of these are with the understanding that this is a cross-trial comparison. Briocad did look at patients who were between the ages of 18 to 60, whereas the SWOG 1826 included older patients as well. And also the patients on Briocad, roughly around 14% of them did end up receiving radiation therapy at the end of treatment, whereas the patients who were on the SWOG trial, only around 1% of them did receive RT at the end of trial. So there's a lot of differences in the trial, the inclusion population as well as the treatment arms in terms of radiation as well. So with all of that included, the emerging role of Briocad is that the 4-year PFS is the highest reported in any randomized trial for advanced Hodgkin lymphoma, and 78% of patients receive full dose treatment at cycle 4. So the discontinuation rates are much lower compared to escalated Biacop. There's higher rates of gonadal function recovery, higher pregnancy rates at the 4-year follow-up, and also meaningful recovery time of cytopenias and other toxicities like neuropathy as well. And also much improved rates in the PET positive. So this is the updated NCCN 2026 guidelines for patients who are fit. You have the option of Briocad supported by the HD21 data. And also you can choose Nivo-AVD or BV-AVD as well based on the SWOG data as well in the relevant population for those who are not able to go through with Briocad. And ESMO guidelines have reflected the same for patients who are young and fit, less than the age of 60 years. A PET-guided Briocad approach is a recommendation. And for those who are between the ages of 60 and 80, Nivo-AVD is an alternative. And if they do not have access to Nivo-AVD, BV-AVD remains an option. So to conclude, what are the things that would guide my choice in real practice? First is that ABVD still continues to be a treatment approach for patients who cannot afford regimens that include the newer agents, either brentuximab or nivolumab. SWOG data does make a point for the inclusion of Nivo-AVD upfront, especially with the availability of generic nivolumab, which does bring down the cost quite significantly. Briocad is a protocol that will have quite a bit of resistance at adoption because of the need for hospitalization. Also, the fact that not a lot of us have much experience giving escalated Biacop. And those who have given escalated Biacop have memories of it being a very toxic protocol. So although Briacad has been compared with escalated Briacop, Briacad is a very different a protocol in terms of toxicity profile, because they've done all the right things in terms of replacing dacarbazine, reducing the dose of exposure to steroid, and also reducing the dose of etoposide and making it more tolerable. But that mind block is always there when wanting to choose Briacad because of our experience with escalated Briacop in the past. The one population where it does make a point is the young fit population, because those who have quite extensive extranodal disease, large mediastinal mass, those who you think are likely to be PET positive at the interim PET, those are the ones I think who would benefit the most with Briacad. And Nivo AVD, again, because of our experience in handling immunotherapy agents across the board in solid tumors, our tendency is to try and underestimate the risk of immune therapies. But in a malignancy like Hodgkin lymphoma with such good long-term outcomes, it's quite difficult having to explain to the patient why they have to continue to deal with long-term immune-related adverse events after the completion of their protocol and continue to be on some sort of a steroid, continue to be on follow-up with the endocrinologist and the general physician, and us as well in the follow-up period. So I think this sets the stage for the next panel discussion to be moderated by Dr. Pavan. Thank you.
Thank you so much, sir. Moving to our next panel discussion.
Yeah, hi. Thanks a lot, Dr. Madhav. The beautiful presentation. I think it's still confusing. I think except Dr. Rajesh, probably here, nobody must have given much of the BCops in the whole practice. My whole training, never I gave a BCop. So it's always now it's Briacad. Definitely makes sense, but I think it's again an experience what will make sense.
Yeah, I agree, Dr. Pavan. I mean, I think I haven't given BCOP here, but I think, again, compared to the other countries in the Europe and UK, the UK was never very much in favor of escalated BCOP upfront. It's usually driven by the Germans in terms of go very big, go very aggressive initially, and then taper down. Whereas I think ABVD had always been the standard of care in the UK. So, and again, I remember using escalated BCOP very, very rarely in the UK, and certainly never in India.
Same, sir. I mean, we are still scared because in a tropical climate with our patients, the finances are tight. Pushing BCops, neutropenia actually takes a toll. And at least I was trained in an era where, again, the Neupogen, the original growth factor was too expensive. 4,000 was a Neupogen then. So it was more costlier than most of the chemotherapy. So we are never trained in it. Once you're not trained, you don't want to practice that in your being a consultant. That's a big problem.
Yeah, we all have our own comfort zones, isn't it? In terms of and 2 or 3 bad experiences, and then it'll drag you down really by a long distance. Yeah.
So in Indian scenario, I always believe that TRM, that treatment-related mortality and morbidity is more difficult to explain than the EFS and OS, what is a typical primary endpoint. So I think we'll go ahead with the panel discussion. We have a experienced panelist. Dr. Rajesh sir is already here. Dr. Sharad Chandra from Omega, Dr. Sujit from RCC, and Dr. Arun from KIMS Health. I think somebody's, this thing is, that's probably, So this is a simple, I don't want to be more formal here. It's a discussion probably as a experience sharing platform. So I will just start the beginning and probably we can share our own experience. So there are 4 cases actually. The first case, the typical upfront young patient, 43-year-old, stage 4 Hodgkins. He had B symptoms to present with. It's a nodular sclerosis type with an IPS score of 5, performance score of 1. So no much comorbidities. So right now, with this scenario, what in your practice, if a young patient comes with a stage 4 disease, no comorbidities, B symptoms, IPS score of 4, probably what would be a treatment approach. Sir, Rajesh sir, you can start the.
Yes. Sure, Dr. Pavan. As we discussed previously, I think we all work in different environments in terms of finances probably being the most important driving force. I mean, in an ideal world, if resources were not a constraint, like working in the NHS or something like that, things would have been so much easier and straightforward. We probably didn't need to have these panel discussions because everybody would probably be doing the same thing.
Correct,
But
sir.
I think the first thing here is still finances. And say if there are financial constraints, I would probably go with ABVD, 2 cycles, a PET guided treatment subsequent. Then I think Nivo AVD or Brentux AVD, I think would probably be my first line go-to regimen. But I think with the Brecad being very much promising, and especially the lure of early termination of treatment with probably significantly reduced toxicities in terms of fertility preservation and all of that, then I think that certainly may be the go-to regime in the future, depending upon the like I mean, if somebody's financially no constraints with regards to the finances. So to be honest, with regards to fertility, I mean, I haven't particularly had so much of a problem with ABVD either. I'm sure you all agree. I mean,
I agree, sir.
yeah, people tend to get
Right, sir. Hello.
patients fertility preservation young. Hello, can you hear me?
Yeah, now we can hear you.
Hello.
It was just
Sure. Yeah. So yeah, I mean that is what I would probably be doing.
So
Dr.
point
Pavan,
taken, sir. Yeah, point taken. I think, like you said, ABVD still stands great because most of the patients are non-affordable finances because, again, the practice totally differs. Probably next we'll go to Sujit. Dr. Sujit, I think you're in RCC. So
Yeah.
what is your experience? You have are still getting away from ABVD or upfront patients, you're still stuck with ABVD because I know it's a different setup.
Thank you, Dr. Pavan. Actually, I totally agree with Dr. Rajesh. So now still the for most of our patients, because once RCC is a government institute and majority of the patient get support through government schemes, and ABVD remains the standard for us. And I don't think immediately it will change. But as you have mentioned, when we do get some financially sound patients, so if like I have seen escalated VCO being given during my DM training, and once you see that, I don't think anybody will give that because we
Yeah,
are more comfortable with ABVD.
correct.
And but still, I had patients. At least we get around 100 plus patient a year, new cases per year, and at least I have 4 5 gliotoxicity. So this is one thing I really worried about ABVD. So as Dr. Rajesh mentioned, we give ABVD 2 cycles, PET CT scan. If PET is negative, we convert to ABVD into 4 more cycles. That's it. But for those patients who are affordable, we go previously we used to give brentuximab BV ABD. Now we are also giving Nivo ABD, especially when the patient is 50 plus. A little afraid to give bleomycin. So Nivo ABD. But the problem with Nivo ABD, as Dr. Madhav has mentioned, Nivo AVD, we give 240 milligram. Is it really needed for the patient maybe 40 kg and the patient maybe 80 kg and we are giving a blanket dose of 240 milligram? In the trial, it was 240 milligram and they have not taken an interim PET. It is a not PET directed therapy.
Correct.
So probably maybe after 2 cycles of PET, you may see something because it's immunotherapy. There will be some immune reaction somewhere and most probably you will end up getting dual score 5 lesions. So that may
Yes.
be the reason they have not included an interim PET. But I really think that Nivo 240 blanket dose, it is not really needed, and something like a PET adapted therapy should come to Nivo. And
I
regarding the BV AVD, few patients we have used it. Majority are ABVD only, but few patients we have used BV AVD also. And there is definitely the risk of peripheral neuropathy, mainly GI side effect and constipation is also there. But now maybe since Bracad is there, It is well tolerated than compared to escalated BCO, maybe a little toxic more than that of ABVD, but maybe with Bracard, sometimes we may rethink because now if we have the confidence, we see more patients, definitely we may be using for, especially for young, maybe that also AVA patients. Because in advance, in stage 3, 4 with high APA, we are aiming at cure rate. Same time maintaining the quality of life and preventing late second malignancy and even infertility. So definitely Bracard is an option. And the other thing, no, when we decide that optimal dose in the phases of in the clinical trial, when you arrive at the dose for the MTD for the phase 2 trial and phase 3 trial. So always we go for the classic, I think 3+3 design where you look at the acute toxicity. That's maybe the reason why nivolumab has reached the 240 milligram, because acute toxicities with most of the immunotherapy is less and they end up having a very high dose. And now I think Hematology Cancer Consortium is coming up both in the first line and in the lab setting with low dose nivolumab plus AVD is there.
I think
And
point taken, Dr. Sujit. So Nivo
mm,
actually, because of before this, the so-called Zydus launched the other things, we used to actually cut down the dose. I used to just stick to 140, 200. Actually, we had good data with 140 and 200. Yeah, like you said, I think we should come to a clear dose. Why we don't need to push the 240 mg. Like all our senior panelists have mentioned, that initially in India right now, the approved treatment is only ABBD, BCOP, or brentuximab ABD. Still, Brecard and nivolumab ABD are still yet to approve in frontline. And the usual point of any treatment is cure is the goal, and overall survival is one of the important points. And we have to optimize the outcome based on the customization. Now, I think this question probably because uh, Dr. Arun and Dr. Sharath can answer this question easily. What is your experience with brentuximab in frontline Hodgkins? Arun, you can start. Dr. Arun?
Hi. Good evening. Yeah, so the experience with brentuximab in Hodgkin's frontline, we have tried in few patients, but the main problem I have come across is the neuropathy. It had become sometimes grade 3, grade 4, where we had to interrupt the treatment. We had to stop brentuximab. So, yeah, patient attained a CR, but there is a risk of neurotoxicity, though ultimately it was reversible. So the experience with brentuximab for me it was not that great. So whenever there is a chance, or for this particular case, I might always opt for either Nivo AVD or ABVD from my experience with BV. But this Bracard has shown promising result, and maybe for very high risk group with bulky disease, high IPA score, Bracard is a promising option, and maybe as time passes and as it gains more popularity, we might also adopt it.
Your experience of using flat 100 mg brentuximab, or you were looking at a typical dose, 1.8 milligram and all?
Yeah, it was the 1.8 mg per kg dose.
You were not having it reduced dose, target 100 mg flat, nothing like that. Because
No.
So with my experience before we go to next thing. So most of the patients again after trial and all, most of the patients we are actually giving 100 mg flat because economical and all. And like you said, neuropathy is always an issue with 100 mg, and we had toxicity. Myelotoxicity is one problem. Though we give growth factor, the myelotoxicity is one problem. Sharath, your experience with using brentuximab?
Used brentuximab more in the recurrent setting.
Okay.
Although one or two patients definitely in frontline have had decent PFS so far. I have used it only off late. But with the advent of new AVD, I have tried low doses more often than the actual flat dosing. Then my usage of brentuximab plus AVD has come down actually after new AVD because of the good experience with new AVD. But brentuximab, yes, sir, agreed. I mean, I also had to cut down on the doses because of the worrying toxicities. Used more of flat dosing, like you just mentioned, not the exact weight-based dosing.
I agree. I think most of us follow because of the availability. this question is again. So, Rajesh, sir, you can answer
Pavan,
this.
do it very quickly. So, I mean, the most of the European or UK protocol with BV-AVD, say the BV is 1.2 milligram per kilogram body weight every 14 days, as opposed to the 1.8, which is for the Brentux given as a single agent every 3 weeks.
Correct.
Yes,
So
yes.
1.2 is the same. Yeah.
Yeah. So, yeah.
So, I mean, I just sorry for the correction, because most of our
Okay.
patients are 70, 80 kg, so 1.2 they cross. Some patients are more than 100. So we have reduced those, correct?
Yes, yeah. I haven't gone beyond 100, yes.
Yeah. So, I think this question we can go to secondary malignancies. Anybody's worried about secondary malignancies in this new treatment, immunotherapy and all? Sujit, you can answer this.
Regarding conventional chemotherapy, I have seen one patient. Actually, that patient had Hodgkin, later had plasma myeloma, and then later had MDS.
Oh,
So, but otherwise, I have not seen with the BBD or the recent like Evo and Brentuximab recently only we have started. So, I have not seen second malignancy
I
with
don't
the
think so.
new novel agents. Yeah.
I don't think so. That should be an issue, because even in when you see pediatric Hodgkins, when we were training in 2010 and 11 and all, so we never said secondary malignancy. And Nivo and Brentux, like nivolumab, any immunotherapy, there's always a worry about probably you getting a secondary malignancy in a long term, because we see the lung data and all. That's always a question mark. Probably, yeah, 5 years down the line, we'll come to know when Nivo data is mature enough. I think the same whole data where Brentuximab with AVD had showed a better overall survival. The first 2 years, it was a trend toward favorable, but subsequently at 6 years and 7 years, there was a better overall survival when in patients using Brentuximab AVD. I think this is the same repetition I just don't want to give. The younger patients, you tend to have a better survival, and definitely a treatment which has a better response. You will definitely have a reduced subsequent secondary treatments compared to the primary. Now, the biggest question, I think already Madhav has put forward the whole thought process. Now, there's no comparison with Nivo and Brentuximab. So the only thing they noticed that above 60 years of age, Brentuximab had a bit, unfortunately, a bad tolerance and lesser EFS and OS compared to nivolumab. So that was very clear. But what they wanted to know that at 18 and 60, the less than 60 years of age, the actual data, there was no much of significant difference in the survival compared to Brentuximab and nivolumab and Brentuximab. And there's no information of secondary malignancy in nivolumab. That's just to put forward the thought that except age more than 60, I think both are same in both ways. SWOG trial, I don't want to repeat it. I think Madhav has just went through all the data. Those SWOG short follow-up 2 years EFS showed a slightly better, not slightly, as a better PFS or EFS at 2 years with nivolumab compared to Brentuximab. The group which actually didn't show much benefit at the age was patients who were, the age group which was more than 60 years had the best benefit. Even between age group 18 to 60, if you take the group, there are almost 24% patients who were actually less than 60 years, 24% patients were below 18 years. And the data and the whole concept comes, patients who are younger than 18 years tend to do better. Probably that added on to the benefit on the group which was less than 60. So this is again a statistical play, so nothing too much. So the whole point, even the deaths during Brentuximab Nivo, less than 60 years, they were same deaths or the same side effects. But patients more than 60, Brentuximab had more deaths compared to patients who had nivolumab. That actually reinforces your PFS. Adverse events, the nivolumab had more neutropenia and especially thyroid profile, hypothyroidism commonly, and the pruritus secondary to all. So inflammatory markers. So the neutropenia was more common in nivolumab compared to Brentuximab. Now, this all point proven taken. So because nivolumab don't have a long-term data, but it's more practical in all sense. I think that's the reason most of us, though we understand, in even the patients who are less than 60 years, we tend to use nivolumab. And it's point taken. Now, I think we'll move forward to the next case, which is more important. So first line, it's again debatable until the Bricard, which probably people tend to use it, it becomes easier. Now, relapse setting, again, very clear, young patients, probably a stage 2 relapsed within, I'll again put the same patient here, 14 months post ABVD, she relapsed, night sweats, B symptoms. At relapse, she is again stage 3. Now, what will be the treatment approach? I think we'll start with Dr. Arun.
Yes, sir. This is a patient who relapsed after 14 months.
Correct. Late
So,
relapse.
yeah, so we should first look for the eligibility for a transplant, and if the patient is eligible, we'll see what he has received in the first. I mean, this patient received only ABV, so he's not exposed to either PDA1 inhibitors or BV. So, for somebody who relapsed after 12 months, we tend to give chemotherapy combined with either of these agents, which can be either a PD1 inhibitor, or we could also combine BV to the chemotherapy.
Okay, so you will definitely use one of these Nivo or Brentu combined with some chemotherapy, get a sort of response 2-3 cycles and transplant.
Yeah, that is, we will choose an agent which yields a higher CR rate, a rapid response, and which is more stem cell sparing.
Rajesh sir, you are still favor of giving chemotherapy with the Nivo or Brentu, or you are moving away from chemotherapy? Again, blunt question. Sir, you are on mute. Rajesh sir, you are on mute. Okay. Sir, I think you are muted, Dr. Rajesh.
Yeah. Can you hear me now? Yeah. Sorry.
Yeah.
So, and again, it's predominantly down to resource constraint. So, if there is no resource constraint, I'd probably go with one of the novel agents, either Brentuximab or Nivolumab with salvage. I have used Pembro GVD in one patient with phenomenally good result. I'm really impressed. I think we managed to secure funding for this really unfortunate chap by various means, and had an excellent outcome after just 3 cycles, transplanted him, and he was only 18. So clearly, I think, but with salvage like ICE or DHAP or
We lost you.
Or reshape or whatever. Yes, if you can get them to see different, but if you're only able to get the experience has been not so great. I mean, most of the PRs relapse very soon after transplant.
Sujit, you are still using chemotherapy in each session? Yeah.
Oh, yeah. Actually, initially we used only chemotherapy. Later, for the refractory and for those who are relapsed within 1 year, we started using. Last year, we have presented the data. Now I have that time it was 11 patients, all attained. That is first line Pembro GVD or Nivois. Sorry, at relapse, Pembro GVD or Nivois for transplant eligible. And 9 patients we had undergone transplant. Almost all of them went into remission. I have more than 20 patients on the chemo immunotherapy, and the results were pretty good. So now we tend to give, even for if it was a later lapse, maybe 2-3 years down the line, we may use chemotherapy. It's a chemosensitive disease. Otherwise, like this, when the patient comes at the borderline, 14 months, we now tend to give chemo immunotherapy. And now we have patients who have failed on. I have patients who have failed on chemo immunotherapy now getting BV plus ICE. She has just completed the 3-third course, and we are awaiting the PET CT.
Dr. you are still, chemotherapy is in part of your system, or?
Definitely, yes, sir. Chemotherapy plus any of these 2 agents, I think I don't do transplant. So most of the patients which I refer to always received Brentux plus ICE, because that is the regimen which my transplant physician wanted always. Although on paper, PD1 inhibitor plus chemotherapy is also have given good results, but so far, Brentux plus salvage is my go-to regimen, and also post-transplant consolidation.
So yeah, my experience, again, there is my slight difference. I have stopped using chemotherapy as any part of the backbone. So we have a good data of almost 14-15 patients from last 1.5-2 years, where we have used only brentuximab with one of the checkpoint inhibitor, Pembro or Nivolumab. Nivolumab was the point we started, but unfortunately, Nivolumab had a very bad PAP program when you relapse setting. So that's the reason we changed to Pembro. So my last 8 patients, 9 patients are Pembro brentuximab. CR rates are almost 90%, and autologous transplant. And right now, as of now, all 14 patients are still surviving without disease. The longest is 3 years. The youngest, the recent is 4 years. So I actually stopped using any of the platinum-based chemotherapies in relapse setting. Now, our setting from last 2.5 years. Again, it's a bias. I have in a setup where I can convince the patient to give it. Again, it's totally conditions apply. So, but now I think Pembro and checkpoint inhibitors plus epithelial antibody plus CD30 antibody ADC actually has a better response rate in the long term. Because I moved away from chemotherapy. That's the reason I'm just putting for my thought. Yes, but everybody's setup is different. I think we are still correct in our own setup. Next question is, where do you place? I mean, this is a question which probably most of us are using brentuximab. So do you still use brentuximab as a post-transplant consolidation or maintenance? You can, Sujit, you can start it from there. Yeah.
So it is post-transplant consultation. So only in patients like I have a patient had primary refractory disease.
Yes.
So I have given chemoimmunotherapy, patient attained CR. Then we were awaiting transplant. He had some fund issues. Once he arranged the fund, he had a note. So he progressed, but we radiated and we had taken the patient for transplant. For such patients like primary refractory or we know the indication like relapse less than 1 year, within 1 year, or patient has extranodal disease. So for this patient, I have considered post-transplant consolidation. We have days we are planning to start that. So yeah, and both pre-transplant, I have just mentioned I have also given a patient brentuximab plus checkpoint inhibitor, but not that common like Dr. Pavan has mentioned because
No.
of the logistic issues,
I
because
know.
the cost will be too high then. And again for the transplant, but transplant is compared to that one dose, it will be enough for me to do a transplant. And post-transplant consolidation, we consider for some patients, selected patients.
Because of time, I think we'll go to next question. I think it's like more like sharing our experiences. So again, we'll come back to the second case, some experience of what we had and all. Third case, we have a patient who had transplant ineligible, more than 2 lines of treatment. So with multiple comorbidities, COPD, hypertension and all, high IPA risk, age 40, 50. So here, what do you expect? What is the best treatment available? Not transplant eligible. So, Dr. Arun, you have any experience like this in these patients?
So here, being a transplant eligible patient, we are just aiming at disease control, maintaining a good quality of life.
Correct.
So a single agent, so if the patient is not exposed to PD-1 before, we could consider single agent Nivo or Pembro, or if he's not exposed to BV, we'll just go for BV, which, single agent BV also will have an overall response rate like 50 to 70%. Even CR rate is almost like 30-35%. So it's again not a bad option.
I think, yeah. Dr. Sharath, you have any experience here? Just giving one of these drugs, continuing without transplant for how long?
Yes, sir. I've had 1 or 2 patients where second or third line I used brentuximab vedotin with good overall response rates, and I have never translated that into a transplant, but definitely good response rates with single agent brentuximab.
How long you could able to continue, Dr.
Sharath? Sir, my patient stopped it because of the peripheral neuropathy after 12 to 14 months.
Oh, good. That's a good number.
Yes, sir. But he's 66.
Okay. Raj sir, you had any experience, Nivo or Pembro, this thing continuing for, as in a refractory setting or relapse refractory setting, was not transplant eligible?
Not here, but I remember one patient we used in the UK. I think the patient was still ticking on 2.5, 3 years since commencing once 3 weekly brentuximab.
Okay.
So, even obviously here, I think I haven't used Brentuximab in that particular setting. But I had one patient who relapsed about 1.5 years or a year plus 3 months after auto. No children, no immediate family who were willing to come forward to see if they were a match. It's only like 52 financial constraints were there, but a year and 3 months down the line, he was just on 3 weekly Pembro. And after 6 months, had CR. Post-transplant, he had a very aggressive relapse with a lot of extranodal disease as well. And 1 year after Pembro, every visit, I've been trying to convince him to go for an allo. Saying, this is Hodgkins, there's potentially very good chance that you'll be cured. But unfortunately, he couldn't take up that risk. And with the non-availability of donor as well as the cost would go up significantly with an MUD. So I'm now thinking of either putting him on the generic nivolumab at a very small dose if he doesn't want to go for a transplant. I've been sending out messages asking him to come back for follow-up. It's been nearly 2 months, I think, since I last saw him. So, yeah.
So, do you have any experience of continuing with one of the checkpoint inhibitors or an ADC sometime?
So I have patients on checkpoint inhibitors. I had a patient, Hodgkin, relapse, advanced stage. So he went to another center from there. He got tapped. He had sensory neural hearing loss, 4 doses of Nivo, CR. Then he was not able to continue. So we have transplanted him, auto transplant. Within 1 year, he relapsed. So again, we re-challenged with Nivo, and within 6 months, he attained CR. Now on monthly dose of 100 milligram nivolumab for more than 1 year, just continuing like that. He's otherwise stable. And I have a patient on single agent lenalidomide across 2 years. Post auto relapse, post allo. Then we have done an allo. It was done by Dr. Srijit, and post allo patient 3 years down the line had a relapse, and single agent single agent lenalidomide 2 years. Now off treatment for almost 2 years in CR.
Yeah, I agree. Actually, we tend to use Len most in our cards, but actually Len works in lymphoma and this thing. So the biggest question comes because most of us now you have ADC. I think we are very clear 1 year. With Nivo and Pembro, how long? So I have a patient's 2 years because Pembro data from the lung comes 2 years. You tend to stop it, right? You tend to stop and probably wait and watch and relapse. You can restart and all. So I have some bunch of patients who not Brentu 1 year. One of the patients took actually 1 year and we had to stop. He's still maintaining a remission. The most of the patients I had was checkpoint inhibitors. They went on 2 years, the 2 years cut off, then I had to stop, then they relapsed, then I took for a allo transplant. So 4 to 6 patients. I think everybody are in the same page. I think we understand that 40 to 50% of the patients tend to have a very good response, even at single agent brentuximab. And the response usually takes somewhere 6 weeks, 12 weeks. You had a better CR. The time to get a CR is usually 12 weeks. I think this part everybody understands. Now, what happens for a patient who relapse after a transplant? We have a young patient who relapse after a transplant. So what is the option? People you want still, I mean, this is a question, again, it's not a transplant alone question. Patient had 2 lines of treatment, had a transplant, now 3rd line. Are we okay with giving a ADC or a checkpoint inhibitor and do an allo transplant? Or how you look at it and how you want to take it? I think, Dr. Sharath, you can start from there. Sharath, you are not doing transplant, but anyway, your experience, you want to refer for an allo transplant or? Yeah.
So far, I haven't done, sir. One good experience is a 23-year-old post auto transplant relapsed in 1 year after using brentuximab consolidation also. He's into the he's now into 2.5 years of nivolumab single agent.
Super boss. Rajesh sir, you have any experience? Patients who have autologous, post-autologous, next, what is the...
Then I would definitely, for the young fit patients, I think allo will be, patients can be salvaged with an allograft as well, in Hodgkins. But if there's no match or other issues, I think it is appealing to continue with the checkpoint inhibitor. Probably, I think we need more data in terms of can we stop after 2 years or can we stop after 3 years. But I think it is easy to reduce the dose and then increase the follow-up between the doses. And I think And I guess everybody does differently, 140 or 100. It's entirely up to whatever you come.
So, Sujit, you will push for a transplant or you're happy with checkpoint
As
inhibitor?
just Dr. Rajesh has mentioned, when young patient fit full mass sibling donor, the cost of allotransplant in our setting is maybe less than 10 to 12 lakhs, and maybe 3 months the cost for immunotherapy will be more than that. So whenever patient has a sibling donor, we push for transplant. Otherwise, like if possible, to continue PDL-1 inhibitors or BV or other palliative options, depending on the financial status of the patient.
Yeah. Dr. Arun, you want to differ or you're
No, I
happy?
also concur with the same.
I have one experience again. So I always felt Hodgkins, the haplotransplants actually tend to have a better survival than your match sibling. So the reason is the post-transplant cyclophosphamide actually does the trick. So we have almost 15, 20 patients, Hodgkins, who have relapsed in a setting. So we did haplo, we do a NMA, the typical Baltimore protocol where we give Fusi and a single TBA and all. Actually, the NRM being less than 5%, these patients actually do well, sir. I mean, if you want to stop off nivolumab and all, haplo actually is one reason we can actually do an haplo transplant because CART is CD38 CART is not available in a country like India. I think haplo is one option because again, it depends on the centers and experience what we do. So haplo is definitely an answer. And even a match sibling, now the data say the post-transplant cyclophosphamide in Hodgkins does better trick than avoiding a post-transplant cyclophosphamide. This just, again, we're just sharing our experiences. Everybody has some experiences, some better experience, some are, that's fine. So anything else as a consultants or we have any questions or experience, probably we can share here. This is the same data which probably will be speaking everywhere. Dr. Sharad, Dr. Arun, Rajesh sir, Dr. Sujit.
My question actually to everyone, whether anyone has used Bracan.
Record, no, no, no from me. I think Rajesh sir is a better
No,
person.
not for me either. No. I mean,
Maybe
I work in a much more research poor setting than yourself, Dr. Pavan. I haven't got the luxury.
No, sir, yeah. No, you're at least trained, British trained, sir. The
No.
problem is we're tropical trained. Although I was trained in Cochin, that's more tropical where you have so fungal infections. I don't want definitely give a BCOP. So trained in a BCOP era. That's the reason.
so. What about the brentuximab plus BV plus chemotherapy? Like
Brentuximab.
now, I think most of us are inclined towards immunotherapy, but I think BV plus chemo also works. The response PFS 3 year PFS is between 70 to
Like
80%.
BBABD. You're saying BBABD?
No.
I
BV
think
plus salvage
salvage.
setting, relapse setting.
Bendamustine BV had pretty good data, and I think before the advent of the
Yeah.
PDL1.
So I think Rajesh sir's thing is we're not able to. There is some disturbance. So I just put for my thought because now I think brentuximab is cheaper with the GST
Yeah,
and all.
with the PAP.
And Nivo has it's just rocketed down in an easier manner. I think I will still understand either need of chemotherapy because when you use ADC and checkpoint, you don't require the toxicity of any platinum-based chemotherapy. That's because this is again 14 patients. It's the most smoothest thing. Nobody complains, no hair loss, nobody complains anything. Yes, it goes on and come back. The transplant is a question. Now, people are thinking should be a transplant because there's a data where people looking at can we avoid transplant if you 5 or 6 cycles of this and you continue one of the immunotherapy for a long time or it's a single mass due radiation. 2 years PFS, they have noticed that almost 70% patients are without disease. Again, that should we transplant or not is a big question. Yes, I just took off away from chemotherapy for the last 2 years. So I still think, I think you don't require chemotherapy. Again, I'm in a different setup where I can push my patients to do it. So, and now with the availability of cost being not a major issue, I think, again, experience, we can have our own experience.
Yeah, I agree. Actually, Brendo BV plus Nivo, now the generic Nivo is also there.
2.6,
Maybe an option,
2.6
yeah.
lakhs. Yeah, 2.6
Yeah,
lakhs.
yeah.
Cycle.
And with the PAP they have, I think that is an option.
Correct.
Yeah, with the PAP, yeah.
Anybody?
And no, yeah, even I have patients who have received PDL1, that is Nivo plus chemotherapy or Pembro GVD, who have not transplanted, not ready for transplanted, consolidated with the 2 more cycles of chemotherapy, and that's it. Now one follow.
Same thing applies to a PMDCL, actually, primary refractory mediastinal B-cell lymphoma. There's a good data with Pembro and, Nivo and brentuximab, because both are CD38.
Oh, yeah.
I tend to have a gray zone concept. Yeah.
Okay.
I mean, any questions, any experience? There's no questions here. I think it's more like an experience. More question is maintenance therapy after transplant in a very young patient. I think that's the question that everybody will ask. Young patient, one of the within 1 year, early relapse, refractory disease, you transplant with something. Do you still give a concept of maintenance, brentuximab, or anything else? Anybody?
Just I mentioned, I have planning to give for one patient now. Previously, I have suggested for patients. But what about Pembro or Nivo? Not in palliative setting, like post-transplant. There is phase 2 data for Pembro and Nivo, but it has not come into the guidelines.
So I use actually, we have 4 patients who actually primary refractory, where we couldn't give brentuximab because of cost. We actually give pembrolizumab, 8 cycles. You can give 8 cycles of pembrolizumab. So these guys are surviving, man. It's 2 years, the longest surviving pembrolizumab. They do well. So if you don't have an option of brentuximab available, it's very clear. So we did give pembrolizumab. So 8 cycles, that's the data. Says 8 cycles of.
That's post-transplant, is it?
Post-transplant, sir.
Yeah,
Post-transplant for high risk.
It is looking appealing. I mean, especially for the very aggressive chemorefractory or.
Correct, sir. Yes, sir. I think Dr. Arun and Sharat, you have anything, any experience or any questions to add? Some disturbance, yeah. We got it. I think, yeah, we reached to the end. I think we are almost near to the time, or we finished before the time. And thank everybody for sharing their experience. And probably I'll leave the platform to the Decade guys to take over. There's no question and answers. So we already finished the question and answers. And vote of thanks, I think I thank everybody, Dr. Sujit, Dr. Rajesh, Dr. Arun, Dr. Sharat, Madhav, to being part of this discussion. Very important discussion, very value-based discussion. So I think we'll call it a day here.